All right, so let's jump right in. In medical imaging, some clues just scream at you, like a big, flashing neon sign. But others, man, they're way more subtle, kind of like a ghost in the machine. And today, we're going hunting for one of radiology's toughest phantoms, a little something called architectural distortion.
Yeah, I know what you're thinking. Sounds like it's straight out of The Big Lebowski, right? But believe it or not, that's how our source material talks about this finding. And you know what? It's perfect, because architectural distortion, we'll just call it AD, is exactly that. It's a sign of potential unchecked aggression inside the body. And it's a puzzle radiologists have to solve.
So, here's our game plan for cracking this case. First, we'll identify our suspect. Then, we'll figure out if it's a friend or a foe. We'll follow the evidence, learn the radiologist's rules, and finally, we'll get to the verdict.
All right, first things first. If we're going to catch this suspect, we need to know what we're looking for. So, what is architectural distortion really?
Okay, so think of it like this. Normal breast tissue has an architecture, right? A normal pattern. AD is what happens when that pattern gets all messed up. It's pulled or twisted or distorted, but there's no obvious lump or mass causing it. It's like finding a footprint at a crime scene but with no suspect in sight. It's a huge sign that something is going on, but the culprit is hiding. A super subtle clue, but an incredibly important one.
So, what does this footprint actually look like on a mammogram? Well, radiologists are on the lookout for a few key things. They might see tissue that looks like it's being tugged inward. That's called focal retraction. But the classic sign, the real giveaway for AD, is seeing these thin, straight lines all radiating out from one central point, kind of like spokes on a bicycle wheel.
But here's where it gets tricky. This is our next big challenge. Just because something looks like AD doesn't mean it actually is AD. There are a bunch of imposters out there, and the radiologist's #1 job is to tell them apart.
And this is the first question they have to ask. See, on a typical 2D mammogram, you've got layers of normal tissue that can just overlap. And that overlap can create shadows and lines that totally trick your eyes. So the big question is, are we looking at a real distortion, or is it just a trick of the light?
And here's how you tell the difference. With a true AD, all those radiating lines, those spokes, they all come together at one single point and then they just stop. But with a summation artifact, that optical illusion, the lines look like they just pass right through each other. There's no central point holding them all together. It's a super subtle difference, but it's absolutely critical.
Okay, so let's say we've ruled out the optical illusion. We know it's a real distortion. Well, now we have to deal with another really common imposter, a surgical scar. See, any kind of previous biopsy or surgery can also mess with the tissue's architecture. So how on earth do you know if you're looking at a harmless old scar or a brand new active threat?
The answer, my friend, is time. This is where old records are gold. A radiologist will immediately pull up any prior mammograms they can get their hands on. Think about it. A surgical scar is just part of the healing process, right? So over the years, it should actually get fainter, less dense, and harder to see. But what if that area of distortion is getting more dense, more obvious over time? Whoa, that is a massive red flag. So you can see how this all builds into a very specific clinical process. As soon as a radiologist spots a suspicious area of AD, and they've decided it's not just an artifact or an old fading scar, a very clear protocol kicks into gear. There's no guesswork at this point. It's a step-by-step, evidence-based pathway.
It all starts on a routine screening mammogram. The radiologist sees something and they flag it as a BRAD 0. Now that doesn't mean it's bad, it just means hang on, we need to get a better look. So the patient comes back in for some special zoomed-in pictures called spot compression views. If that distortion is still there, the next step is an ultrasound to see it in a different way. And by this point, yeah, the finding is almost always getting categorized as highly suspicious.
And listen to this, because this is maybe the most important point of all. Architectural distortion can be so sneaky, so subtle that sometimes it doesn't even show up on the ultrasound. It's just invisible. But here's the thing. It doesn't matter. The initial finding on the mammogram is considered so suspicious that even with a totally clear ultrasound, the recommendation is exactly the same. This needs a biopsy. We have to know for sure what's going on.
So with all that in mind, what are the bedrock fundamental rules that guide a radiologist through this whole complex investigation? Let's kind of break down the key principles they have to live by whenever they come across AUD.
Okay, so these are the big ones. Those radiating lines to a single point,
That's your classic sign of AD. Now, if you see those with tiny little calcium deposits, what we call calcifications, that often points to something called invasive ductal carcinoma, or IDC, along with its precursor DCIS. But if you see the AD without any calcifications, well, that's more suspicious for a different type, invasive lobular carcinoma, or ILC, and that one's known for being extra sneaky. And of course, always remember, time is the key for telling scars apart, and even if an AD seems like it's been there for a long time, it still gets the full workup.
And I gotta say, I love how the source material puts this next one. There is one unbreakable rule. A radiologist should never, ever, 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 ever call an area of AD a BI-RADS 3. BI-RADS 3 basically means, it's probably benign, let's just keep an eye on it. No way. AD is never probably benign. It is always considered suspicious until you can prove it's not.
So all of this brings us to the end of our investigation. After following all the clues, navigating past the imposters, and sticking to the rules, we finally arrive at our final verdict. And when it comes to architectural distortion, let me tell you, that verdict is crystal clear and totally non-negotiable.
Here's the bottom line. It doesn't matter what. It doesn't matter if it's seen with calcifications or without them. It doesn't matter if the ultrasound shows something or shows absolutely nothing. It doesn't matter if it's brand new or if it looks like it's been there for a while. Architectural distortion gets a biopsy. Period. The finding is just way too suspicious to ever just watch and wait.
And that really just leaves us with one last thought, doesn't it? This whole process, it highlights such a core principle in medicine. You know, when you're dealing with a finding as subtle and elusive as architectural distortion, the biggest risk isn't being wrong about a biopsy. The biggest risk is not being suspicious enough to begin with. It's a reminder that the entire system is built around asking one single powerful question. What are the subtle things that we are trained, above all else, never ever to miss?